Hello and a very warm welcome to everyone attending the STR Bootcamp. My name is Rachna Madan from the Brigham and Women's Hospital in Boston, and I'll be talking about the visceral or middle mediastinum. Now, this is an interactive session, which means that I'll be sharing some questions as we go along. So please take your time to think of the best answer. And once you've had a chance to do so, I'll be revealing the answer. I have no disclosures relevant to this presentation, so let's jump right in and see how we're going to approach this topic. We look at the boundaries and contents of the middle or visceral mediastinal compartment. We review some important radiographic signs to help detect and accurately localize visceral mediastinal masses, and then look at the imaging appearances of some masses on CT and MR and how that helps us to refine differential diagnosis in these cases. And lastly, review some mimics of visceral mediastinal masses. Now, first we'll begin with anatomy and some radiographic signs. Now, you may be familiar with some classification systems of the mediastinum, and what I'll be focusing on today is a CT-based classification system which was proposed by the International Thymic Malignancy Interest Group a couple of years ago. And for that classification, the visceral mediastinal compartment is superiorly bound by the thoracic inlet, inferiorly by the diaphragm. Anteriorly, you have the boundaries of the prevascular compartment, and posteriorly, you can draw a vertical line connecting a point on each thoracic vertebral body approximately 1 centimeter posterior to its anterior margin, and then you'll have the posterior boundary. Now, this space contains the trachea, carina, esophagus, and some lymph nodes, as well as the heart and all the major vessels and the thoracic duct. So here you can have a look at this space on CT. This is the area shaded in blue, containing the heart and the great vessels and the trachea, carina, and the esophagus. So coming to our first question for this talk, which imaging sign is shown here? I'll let you look at the image and review the options here, and you can think of the answer. So the correct answer is the hilum overlay sign. And this sign was described by Benjamin Felsen and is quite helpful for localizing juxtahilar mediastinal masses, so like you see here. And what this sign states is that if the left or the right pulmonary artery is seen more than 1 centimeter or more deeper to the lateral edge of a juxtahilar mass, so that means that the vessels can be seen through this mass. It means that the mass is either anterior or posterior to the hilum and likely represents an anterior or posterior mediastinal mass. So it's not going to be a middle mediastinal mass. It's not going to be a part of the cardiac silhouette. So in this case, the mass was in the prevascular space, and you can see this bilobed sort of a mass containing fat, a Rokitansky protuberance, some cystic component. This is a bilobed cystic teratoma. So here's a companion case and our second question. And you can take a look at the radiograph again and think of which imaging sign is shown here. Now your options are here. You've got 4 options. And the correct answer is the hilum convergence sign, which is quite helpful in distinguishing between an enlarged pulmonary artery and juxtahilar non-vascular mass. So in this case, you can see the pulmonary artery branches appear to converge towards the apparent hilar mass, suggesting that this is an enlarged pulmonary artery. So you don't see the vessels seen coursing through the mass, they're converging on the mass. And this is better shown here in the schematic diagram. You can appreciate the difference between these two signs. Here you have the hilum overlay sign where the vessels are coursing through the hilar mass, and the convergence sign where the vessels are converging on the mass. And this is the CT to go with the chest X-ray that I just showed you. This patient has an uncorrected left to right shunt and Eisenmenger syndrome and aneurysmal extreme dilatation of the pulmonary arteries with thrombus formation. So this is the high limb convergence sign in a patient with aneurysmal pulmonary arteries. Now we have another question here at this point, and we have both frontal and lateral chest radiographs, and you can look at this X-ray and think of where is the location of the abnormal finding here. And again, 4 options. So you can take a few moments. So the abnormality is in the retrotracheal space, or the Rader's triangle, as it's called sometimes. And normally this space is lucent. You normally see a lucency behind the trachea. But in this case, you see a mass-like opacity, which is causing bowing of the trachea anteriorly. Now, sometimes this is caused by congenital vascular lesions, such as a right aortic arch with aberrant left subclavian artery, which is what was present in this case. And sometimes you can have a left aortic arch with aberrant right subclavian artery, sometimes esophageal tumors and duplication cysts. And as a result of the location of these masses, the patients can present with stridor and dysphagia. Now, next, coming on to tissue characterization of masses with CT and MR. And to me, this is really the fun part of, and the most exciting part of looking at mediastinal masses. Now, in most cases, CT does quite well. It localizes the mass to the correct compartment, and you can perform tissue characterization, picking up on macroscopic fat, cystic component, calcification, hemorrhage, hypervascularity. And it will give you a narrow differential diagnosis, in some cases a specific diagnosis, and aids in decision-making and management, which is appropriate for the case. Now, where CT is less well-suited is when you are dealing with a mass which has complex fluid with hemorrhagic or proteinaceous contents or milk of calcium, or when you're trying to delineate microscopic fat with septations. So here, MR is a much superior imaging modality. It readily distinguishes cystic from solid lesions. It delineates lesion complexity and tissue content in a lot of detail, picking up on proteinaceous and hemorrhagic material, microscopic fat, fibrous tissue, septations, and subtle or delayed enhancement in these masses. So we really want to add advanced imaging like MR or PET-CT where management changes significantly, such as you do this imaging and it avoids surgery or biopsy, or it helps suggest a specific alternative diagnosis. And this happens in a couple of different clinical situations. So when you're dealing with a hyperattenuating mass on CT, it may be due to cyst with hemorrhage or proteinaceous contents, or it could be a solid tumor, or you may have a complex cystic mass with equivocal solid component and septations. Or you may have a case where you have multiple intrathoracic lesions and you're not sure if this is related or unrelated. So let's look at lymphadenopathy, which is the most common disease process of the visceral mediastinum. And I'll just share a couple of examples. So it can be benign, or it can be malignant, frequently seen due to infections such as mycobacterial and fungal infections. Sarcoid is another important cause of lymphadenopathy in the mediastinum. So there's a wide variety of causes of adenopathy. So you can try to ascertain the cause of lymphadenopathy somewhat based on the CT appearance. So if you're looking at hypoattenuating nodes, as in they're appearing very cystic or necrotic, think of mycobacterial infections or non-tuberculous mycobacterial infections, nocardia, sometimes even cystic or necrotic metastasis. Hyperattenuating nodes may be seen due to sarcoidosis and old granulomatous infections. And hypervascular nodes may be seen with Castleman's disease or patients with hypervascular primaries leading to metastasis. So here are two examples. Here you have a patient with a sarcoidosis, and you can see this very symmetric mediastinal and hypervascular. The nodes are quite discrete, relatively hyperattenuating to the heart and the liver and the muscle. And here you have a patient with HIV and low CD4 counts who presented with this very bulky, cystic and necrotic looking lesions in the right paratracheal and subcarinal regions. So these were sampled and found to be nocardia, due to nocardia. So a very striking appearance of nocardia infection involving the lymph nodes. Now let's look at an example of a complex cystic mass in the visceral mediastinum. Now this was a young woman who presented with a subcarinal lobulated cystic mass, and it seemed to insinuate between adjacent structures. We thought that there might be a solid component or a septation here, but weren't very sure. Now with this appearance and in this location, we thought that this could be a cystic lymphangioma or a bronchogenic cyst or a pericardial collection or a necrotic mass. So very broad differential, which was not very useful. So decided to add an MR here, which convincingly showed the presence of thin septations, no solid component. So this was likely a cystic lymphangioma and not a foregut duplication cyst. And so the patient was able to undergo the correct management, which was cyst aspiration and marsupialization in this case. And let's look at some hyperattenuating masses in the visceral mediastinum. Now, masses may be hyperdense or hyperattenuating because of their hypercellularity, such as what happens in lymphoma, in which case the enhancement is mild to moderate, or it may be due to the hypervascularity of the mass, such as what happens with paragangliomas and Castleman's disease, and the enhancement is quite intense and brisk. And sometimes you may be dealing with cysts which have complex contents containing hemorrhage or foregut duplication cysts with proteinaceous contents or milk of calcium. And in these kind of masses, the enhancement is quite equivocal and indeterminate. And this is where you can really benefit from addition of MR and specifically subtraction sequences, which allow you to see if there is any true enhancing soft tissue component. So let's look at an example. This was a patient with a very well circumscribed hyperdense mass subcarinal region. This is isodense to the muscle and the liver. The attenuation value is close to 65. And so we know that hyperdense bronchogenic cysts usually occur in this location, but are we absolutely sure that this is not a solid mass like a leiomyoma or a fibrous tumor or a lymph node? So at this point, we decided to add an MR, and the lesion was uniformly hyperintense on T1, mildly hyperintense on T2, and no enhancing component on subtraction images. So this confirms that this is an acellular lesion. This is a bronchogenic cyst with milk of calcium and not a solid tumor. And it is the subtraction images which really confirm the absence of any true enhancing component amidst intrinsic pre-contrast hyperintensity of this lesion. And so you're quite confident about your diagnosis here. Now here's another mass, same location, almost a radiological twin, if you will, a very solid looking mass. So again, based on our experience, can we assume that this is a hyperdense bronchogenic cyst, or should we confirm this with more imaging? So in this case, a PET CT was done, and this lesion is bright as the sun. So this suggests a cellular and a very aggressive neoplasm. This was actually a sarcoma. So a cyst in this location would have been photopenic. So the point of sharing these two cases is that many subcarinal hyperdense masses will be duplication cysts, but you must prove that with additional imaging of some kind, either MR or PET CT, before deciding on no further follow-up or tissue sampling, or occasionally you will miss an aggressive mass like this, which will have implications for your patients. Now, this was another patient who presented more acutely. There was a history of anticoagulant use, and the patient developed sudden dysphagia. And you can see this relatively hyperdense and somewhat mixed density mass here, which had the appearance of a collection on sagittal images. And we thought that given the history, the patient likely had an intramural esophageal hematoma, but the surgeon was worried that maybe there was a tumor and the patient bled into that. So fair enough, we did both an MR and PET-CT, and this actually did look quite like a collection. There's only a thin septation here, and the lesion was absolutely photopenic on PET-CT. So this was indeed an intramural esophageal hematoma, and with the help of MR and PET-CT, we were able to characterize this as a hematoma and not a hemorrhagic tumor. So, and then we could manage this patient conservatively. Now, moving on to hypervascular masses in the middle or visceral mediastinum. And the reason it's important to recognize hypervascularity in a mediastinal mass is because, one, it'll actually help narrow the differential diagnosis for you to a select few entities. So in the visceral mediastinum, you think of paraganglioma, Castleman's disease, and maybe metastatic disease from a hypervascular primary. But more importantly, hypervascularity entails a propensity to bleed, so you should consider preoperative or pre-surgical embolization in these patients. And know that open surgical procedures are actually safer options and will allow better control of hemorrhage in these patients. So here's a patient who presented with very classic history of refractory hypertension, not responding to treatment, palpitations and flushing. And we saw this briskly enhancing solid lobulated mass in the very closely related to the lesser curve of the aortic arch. It's enhancing just similar to the aorta. So this is a very good location for a paraganglioma. Now, based on its proximity to aorta, we thought that there might be intravascular or intracardiac extension, and so we did a gated cardiac MR, and you can see these dark blood double inversion recovery sequences, but we did not identify any intravascular or intracardiac extension. So this was a case of paraganglioma, very hypervascular tumor. So in these patients, you should definitely consider pre-surgical or pre-biopsy embolization. Now, next we look at a case of where MR picks up on some imaging finding which suggests that these lesions are matching or related to each other. So this patient presented with low-grade fever and weight loss. And on imaging, we saw very extensive infiltrative soft tissue abnormality in the subcarinal region, encasing the esophagus and extending below the diaphragm. So very extensive. And so based on the history and the imaging findings, we thought this could certainly be lymphoma. It could also be some sort of mediastinitis with abscess or phlegmon, and then also something rare like IG4 disease. So in this case, we did MR and not PET-CT, and we saw the patient had multiple cystic lesions within this infiltrative soft tissue abnormality, which was not appreciated on CT, and these were seen extending into the abdomen, and the patient also had some peripancreatic fluid collections and pancreatic ductal dilatation. So all of this was suggestive of pancreatitis with pseudocyst formation, which was extending into the mediastinum. So this was really extensive, and MR is sort of like one single imaging modality which can give you all the answers, giving you the extent of disease and exactly what is going on in this patient. Now, last, I would just want to share some mimics of visceral mediastinal masses. And I'm sharing images from two patients, and you can think of the possible diagnosis here. And so both these patients actually have prominent pericardial recesses or diverticulae. So incidentally, both patients had been referred for biopsy of necrotic paratracheal or necrotic paraaortic adenopathy. And when MR was done, we saw that these were fluid signal. There was no enhancing solid component. So this was a case of superior periaortic pericardial recess, and this was pericardial recesses surrounding the left pulmonary artery communicating with the pericardial space. So sometimes these patients get referred for unnecessary surgical procedures and biopsy of some necrotic nodes, but knowing the typical location of these pericardial recesses helps avert unnecessary surgery or any sort of further imaging follow-up in these patients. And here's our last question. There are a couple of CT images and a PET CT image. And you can think of what would be the best descriptor for describing these findings on CT and PET CT. These options are a little wordy, so I'll give you some time to think of these, the answer and look at the images. And so the correct answer actually is this patient has nodular soft tissue thickening of the pericardium and several pericardial recesses. Now, this may be due to some sort of metastatic disease involving the pericardium or mesothelioma. And the reason this is not confluent adenopathy or mediastinitis is, look at the encasement of the great vessels and the coronary arteries by this soft tissue abnormality. And here you can see more nodular thickening of the pericardium. And the fact that this is showing a prominent uptake on PET CT means that this cannot be just simple fluid. So this is not a loculated pericardial effusion. So this distinction and accurate anatomic localization, being sure if this is pericardial thickening or confluent mediastinal adenopathy, is very important because it allows selection of the best access for tissue sampling. And in this case, it would be VATS or video assisted thoracoscopic surgery and not mediastinoscopy. So that brings us to the end, and I'd like to conclude my presentation. Thank you so much for your attention and participation, and good luck. Thank you.